Coming to question 9 of NEET PG 2024. 45 years old female presents with chest pain, dyspnea and syncope. Which of the following suggests aortic stenosis rather than aortic regurgitation? You need not see the first part here because the question is in the second part only. You have to find out which option suggests aortic stenosis rather than aortic regurgitation. But anyway, we'll read the question. Chest pain, dyspnea and syncope, this is the triad of aortic stenosis. And we also have a triad of aortic regurgitation, which is chest pain, dyspnea and palpitation. Syncope occurs in aortic stenosis, palpitation occurs in aortic regurgitation. So we'll just discuss pathology. I am drawing a box diagram of the heart. So this is the right atrium, right ventricle, left atrium. Maybe we'll use a different color. Right atrium, right ventricle, left atrium, left ventricle. So we know very well that deoxygenated blood from the SVC and IVC empty into the right atrium. From the right atrium, through the tricuspid valve, blood enters from the deoxygenated blood enters the right atrium to the right ventricle. From right ventricle, we have another valve, the pulmonary valve, through which blood goes from the right ventricle to the pulmonary artery. Remember, pulmonary system is a high capacitance, low resistance system, which means the total pulmonary pressure is only around 25 millimeters mercury. So blood through the pulmonary artery becomes the pulmonary capillaries, where oxygen exchange occurs in the lung, and they form 4 pulmonary veins, and the 4 pulmonary veins empty into the left atrium. From left atrium, oxygenated blood enters from left atrium to left ventricle through the mitral valve, and blood enters from the left ventricle to the aorta through the aortic valve. This is the aorta. Aorta is in contrast to pulmonary system, aorta is the high pressure system. So we know very well the normal aortic pressure is around 80 to 120, right? Okay. So this is how blood flow occurs. In aortic stenosis, what happens? Aortic stenosis is narrowing of aortic valve less than 2.5 centimeters square. So when aortic stenosis occurs, what happens? There will be fixed flow stenosis. That there will be flow limitation from the left ventricle to the aorta. So when blood flow to the aorta reduces, what happens? There will be syncope. So this is the reason for syncope in aortic stenosis. Now, since left ventricle is not able to pump blood into the aorta, what happens? The left ventricle will try to increase itself by causing pressure hypertrophy to force the blood into the ventricle. So there will be pressure hypertrophy. So there will be pressure hypertrophy of LV to push blood into the ventricle. Now when hypertrophy occurs, what happens? Hypertrophy is increase in size of the cell. So when the left ventricular cellular size increases, when left ventricular hypertrophy increases, the demand of oxygen increases. Whereas the blood supply remains the same, so this leads to a demand-supply mismatch. So this leads to a demand-supply mismatch. This demand-supply mismatch leads to cardiac ischemia and chest pain. So this is the second part of the triad. So syncope, how does chest pain occur? Now, even though LV tries to hypertrophy, it cannot push every blood into the aorta through the stenosed aortic valve. So some amount of blood will go back into the left atrium by back pressure. The back pressure gets transmitted to the pulmonary vein, to the pulmonary capillaries, and pulmonary capillaries leak out, leading to pulmonary edema. So the back pressure leads to increased pulmonary capillary wedge pressure or pulmonary edema. That's the reason for breathing difficulty. So this is the pathophysiology of aortic stenosis. Now on the contrary, what happens in aortic regurgitation? So we'll draw a diagram like this again. We'll concentrate only on the left part. See, remember, stenosis, whether it is mitral stenosis or aortic stenosis, is always a systolic problem. Blood does not enter from the left ventricle to aorta during systole, whereas regurgitation is a diastolic problem. So what happens here? Normally, during left ventricular diastole, the aortic valve should close completely and it should not allow any blood flow from the aorta to the left ventricle. But in regurgitation, what happens? There is a small gap. So during diastole, the aortic valve does not close completely. So some blood from the aorta will come back into the left ventricle. This leads to increased volume of the left ventricle. So in due course, it leads to volume overload hypertrophy or volume hypertrophy. In aortic stenosis, it is pressure hypertrophy. Here it is volume hypertrophy. Whenever volume increases in any cardiac chamber, it leads to palpitation. Okay. Now, when blood from the aorta goes into the left ventricle, the aortic pressure decreases very much. We know very well that the coronary circulation or the heart gets its main supply from the coronary vessels, especially during diastole. So in diastole, since aortic blood regurgitates into the left ventricle, what happens here? The coronary pressure decreases. So there is coronary hypoperfusion, leading to cardiac ischemia and chest pain. So the chest pain in aortic stenosis is due to demand supply mismatch, whereas the chest pain in aortic regurgitation is due to coronary hypoperfusion. This process is more significant in the night. So it leads to nocturnal angina. Why in the night? Heart rate is low, diastolic time is more, so chest pain is also more. But so when left ventricle gets overloaded with the blood, the same thing occurs. The back pressure goes into the left atrium, into the pulmonary vein, and pulmonary artery, pulmonary capillary pressure increases, leading to pulmonary edema. So this leads to breathing difficulty. So this is the triad of aortic regurgitation. So we will read the options here. Aortic stenosis causes reduced pressure on the aortic valve. No. Aortic stenosis, left ventricular pressure is so high due to pressure hypertrophy, it causes increased pressure on the aortic valve. So this is the wrong option. So increase in myocardial oxygen consumption is seen with pressure overload than with volume overload. Yeah, correct. This is what we had discussed. The ischemia in or chest pain in aortic stenosis is due to demand supply mismatch, whereas in aortic regurgitation is due to coronary hypoperfusion. So this is the right answer. Workload has nothing to do with myocardial oxygen consumption. Wrong. We know the Laplace's law. Wall tension is directly proportional to the pressure. So more pressure, more workload, more oxygen consumption, right? So increase in preload more than afterload. It is actually the reverse. Because in aortic stenosis, afterload is high because there is a stenosed aortic valve. Left ventricle is pumping more to push blood against the stenosed ventricle. So afterload is more in aortic stenosis. Whereas preload is more in aortic regurgitation because at the end of diastole, left ventricular volume is so high. So whatever blood is accumulated from the aorta into the left ventricle during diastole, during the next systole, the left ventricle has to pump the same extra amount of blood into the aorta again. So heart is preloaded in aortic regurgitation, whereas the afterload is more in aortic stenosis. Okay. So this question can come in physiology also, but if you discuss it here, it may be useful. So you should also know about mitral stenosis and mitral regurgitation, right? In mitral stenosis, left atrial enlargement will occur because the left atrium will try to pump blood into the left ventricle against the stenosed mitral valve. What happens in mitral regurgitation? During diastole, atrial diastole, blood from the left ventricle goes back into the left atrium because of incompetent mitral valve. So left atrium gets distended, but during the next systole, the entire left atrial blood comes back into the left ventricle. So actually, if some question comes, LV is actually loaded in mitral regurgitation. It is not LA because left atrial volume is low. So even though there is a backflow, it will come back again into the left ventricle during the next systole. So left ventricle is loaded both in ER as well as MR. Okay, this completes this question.